Computer-aided diagnosis, also known as CAD.
CAD is a system created to assist radiologists with their diagnosis by helping them with interpretations of medical images. CAD is often not a primary source of diagnosis, and its main goal is to decrease the rate of false diagnosis by assisting radiologists with a second opinion. CAD uses a pattern recognition software that detects unusual patterns on the image for the radiologist to take into consideration when making a diagnosis. With CAD, radiologists use the computer output as a second opinion and make their final decisions accordingly. In some clinical cases in which radiologists are confident about their judgments, radiologists may agree with the computer output or disagree and then disregard the computer's opinion. Although for cases in which radiologists are less confident, it is expected that the final decision can be improved by the use of a computer output. This improvement is possible, of course, only when the computer aid is accurate. The higher the performance of the computer, the better the overall effect on the final diagnosis. However, the performance level of the computer does not have to be equal to or higher than that of a radiologist. With CAD, the potential gain is due to the synergistic effect obtained by combining the radiologist's competence and the computer's capability. Because of these multiplicative benefits, the current CAD system has become widely used in practical clinical situations. Most hospitals don't use CAD as the primary source of diagnosis, since it is not an automated computer diagnosis where the final decision made is solely dependent on the computer output. There are typically 4 general schemes for a computer-aided diagnosis system: pre-processing, segmentation, feature extraction, and feature classification. The first step is pre-processing. In this step, the image is being processed into a sufficient enough quality so that the computer is able to recognize it. Filters are applied as well as window level adjustments to change image contrast. The main goal of this step is to reduce noise and image artifacts. Here, we can see an image of a lung. The image is processed so that only the tiny nodules and dots remain. These nodules can either be normal or cancer. The second step is segmentation of body regions. In this step, the computer uses the data from anatomic data bank to identify whether the region of interest on the image represents mass, microcalcification, or tissue. The third step is feature extraction. In this step, the region of interest is analyzed for special characteristics, such as morphological features, gray level features, texture features, wavelet features, and more. The final step is feature classification. In this step, the goal is to apply various algorithms to classify whether the identified structure is benign or malignant. The algorithms also differentiate true lesions from a normal anatomical structure.
When we look at CAD, the system by itself is not developed enough to be used on its own. However, if used properly by human, it can be beneficial for both the physician and the patient. This is similar to a concept of the cyborg, as it is a combination of robot and human coming together to form something that is more powerful than just a man or a machine. The physician, along with CAD, can lead to a more accurate image diagnosis, and therefore the physician can be more confident with his reading when supported by the computer. Now, let's talk about the history of computer-aided diagnosis.
The concept of CAD was first reported by Fred Winsberg in 1967. Winsberg and his team examined the use of computers to analyze the detection of abnormalities on mammograms. In 1972, the concept of CAD was expanded by classifying 4 properties a computer could use to detect lesions on mammograms. They are calcification, speculation, roughness, and shape. Many other features have been defined since this initial classification. In the US, the CAD system was approved by the FDA for radiographic mammography in 1998 and for digital mammography in 2001.
The use of computer-aided diagnosis.
CAD can be applied to almost every modality you can think of: CT, ultrasound, MRI, and mammography. It is mainly used in diagnosis of breast, lung, and colon cancer. This is because a large fraction of these examinations gives normal results, and the detection of only a small number of suspicious lesions by radiologists is considered both difficult and time-consuming. Therefore, it is reasonable that the initial phase of practical CAD in clinical situation has begun in these screening examinations. So how does CAD work with these modalities? For this video, we will be focusing on how it works with mammography and ultrasound. In mammography, CAD will help find and magnify areas of concern found on mammogram. Mammogram films are loaded into a special processing unit that will digitalize the mammogram images. CAD will look for abnormal areas of density, mass, or calcification that may indicate the presence of cancer. These abnormalities will be highlighted, and the radiologist can determine whether the areas marked by the CAD are abnormalities that need to be followed up or not. In ultrasound, the process is similar. Some advanced ultrasound unit has included CAD as one of their features. When the CAD system detects a lesion, its border will be drawn automatically. The lesion will be analyzed, and the ultrasound unit will give suggestions to the sonographer about the characteristics of the lesion. It will also give a recommendation on whether the lesion is benign or malignant, based on a deep learning detection algorithm.
The benefits and the effect of computer-aided diagnosis. CAD can help improve the time efficiency as it can help slightly reduce the time for an image diagnosis for certain cases. CAD can help increase the accuracy in image diagnosis. CAD may be able to detect diseases when they are too small or in the early stage and cannot be seen by a human's eye. This allows for early diagnosis, and early diagnosis can be beneficial in helping improving the patient outcome. A research study done in 2001 found that when CAD was used by a radiologist, there was a 19.5% increase in the number of cancer detected, as well as an increase of 5% in the proportion of early-stage malignancies detected. Moreover, CAD can help reduce the workload for highly experienced radiologists, as the system can help improve the accuracy and interpretation time when used by a less experienced physician. This will allow for less stress and demand for highly experienced radiologists, and therefore get increased in productivity.
The benefits of CAD. Just to reiterate what was said before, CAD assists radiologists and does not diagnose for them. Radiologists are put to the test when lesion incidence rates are low, such as lung cancer, the error rate is high, such as mammograms, and the image volume is also high, such as chest CT. They are also used in vascular imaging. They're used in detection of lung nodules for lung cancer and microcalcifications for breast cancer. Among 12,000 mammograms done, the radiologist performance was measured using CAD and without CAD. The recall rate for patients increased from 6.6% to 7.7%, and the proportion of early stage malignancy detection went from 73% to 78%. This represents an increase in efficiency in detection of cancer when using the CAD system.
Computer-aided diagnosis can also have a negative effect on the quality of patient care. An example of this would be the usage of CAD in mammography. When diagnosing a mammogram, radiologists will be looking for microcalcification to check for any sign of breast cancer or abnormality in the tissues. By looking at the breast image in this picture, the radiologists are trying to look for little white triangles that could indicate sign of cancer tumors. However, on the left image, you can see that there's a yellow circle around the white triangles, and that was actually placed there by radiologists, and they represent cancer tissues. However, as you can see, there are also many other little white triangles on the image, and if the computer picked these triangles up and identified them as cancer, this is what we call a false positive. And due to this, the CAD system for mammography is not that great. And because it's not that great, sometimes the radiologist may choose to ignore the computer, and the one time when the computer actually picks something up useful to look at, the radiologist ignored it, and then cancer was missed. The financial cost and implementation of a CAD system.
So, what are the financial costs and cost effectiveness to implementation? The costs vary in broad ranges depending on modality, type of exam conducted, or country of origin. For example, the Makarov model was developed to see cost effectiveness in mammography screening program. Adding CAD to mammographic screening program resulted in a MCYLS marginal cost per year of life saved of $19,058. CAD increases the marginal effectiveness of screening by 29%. However, the marginal cost of screening is also increased by 34%. Overall, the MCYLS is 19% greater for CAD added to screening versus screening mammography alone. CRC is a colorectal cancer, and CT modality is actively used to diagnose this type of cancer using a colonography exam. When introducing CAD to CT, it resulted in 9 to 2% increases in CRC prevention rates for inexperienced and experienced readers respectively, when compared with CT colonography without CAD. The overall program costs increased only by 3 to 5%. largely because of the substantial reduction in CRC-related costs. CAD-induced CT colonography exam also became more cost-effective and clinically effective than optical colonoscopy and FS, flexible sigmoidoscopy. For optical colonoscopy examinations, the cost-effectiveness of $498,668 per life gained. For CT with CAD, the numbers are greatly smaller, $61,358 per life gained. Therefore, the addition of CAD to CT colonography screening improves the CRC prevention rate, resulting in advantageous cost-effectiveness for screening. Will the technology easily fit within an already existing imaging infrastructure? According to the article, the separation of CAD into different schemes in the future is highly possible. It is suggested that CAD schemes will be implemented into the software of the certain specific imaging modalities like MRI, digital mammography, and CT. Meanwhile, other schemes will be included into packages and become a part of packs. These pack packages will be very specific regarding their imaging goal. For example, the CAD package for chest will be focused on a computerized detection of lung nodules, cardiomegaly, and vertebral fractures. This package may also include the computerized classification of benign and malignant nodules and the differential diagnosis of interstitial lung diseases. There are two main ways how radiologists may use the CAD package. The first method is to read images without the computer output and then to request a display of the computer output before making the final decision. However, this method minimizes a chance of a false diagnosis, but it's very time-demanded. The second one allows displaying the computer output first and then the final radiologist's decision. This method is obviously a time saver, but it is uncertain whether lesions can be missed when no computer output was shown due to computer false negatives. The problem of following the second method can be overcome by increasing sensitivity in the detection of abnormalities, which may be possible with a package of complementary CAD schemes. This would be one of the potential advantages in packaging of a number of CAD schemes in the PACS environment.
In conclusion, we just want to further emphasize that computer-aided diagnosis is used as a secondary source of diagnosis. The radiologist is still the primary source of diagnosis, and that means the radiologist will make the final decision, and the CAD system will only come in as a second opinion. Although CAD has become a part of clinical work in detection of breast cancer used in mammograms, it still has a long way to go from reaching its full potential. There are a lot of ongoing researches that aim to improve the performance of CAD. In the far future, it is likely that the CAD system will become available for all modalities and complex algorithm, along with machine learning will be developed to enable the system to diagnose an image on its own, and ultimately become the primary source of diagnosis. And this brings us to the end of our presentation. Thank you for listening.